chapter, we had lots of questions after the end, after talking about this cycle of hormones. And many of those questions focused on, well, where does birth control come in and how does it affect that system? So we talked at length about that on Thursday. But to just go over some example birth control strategies, you'll note that of all of these, only two, this one and this one, work on the male side of things. So like we talked about with the male reproductive system, it's hard to arrange infertility in the male because the male system evolved to produce huge numbers of gametes. And any one of those can cause fertility, can cause a pregnancy. So we have the barrier method and the surgical method. So in a vasectomy, can you hit that front light for me? This is still really washed up. The vas deferens or the ductus deferens are either clipped with a little metal clip to squeeze them shut, or are cut and both ends tied. This would be the irreversible kind, where the ductus deferens are separated and tied at both ends. This is more likely to succeed. The clip works, but it is more likely to fail. And in theory, it's reversible, although not always. Okay? We talked about the progesterone-only pill and the oral contraceptive last time. Depo-Provera works just like the progesterone-only pill. So it's progesterone that's been mixed with an oil so that it stays put for 3 months and lets out a little progesterone all the time. It's good for people who have a tendency to forget the pill, right? Because you don't have to remember. This is the IUD that we talked about last time. So it's a little T-shaped device. The top of the T is flexible so that it can squeeze together. And it fits up through the cervix like that. And then the arms spread apart. So the arms go here, and the body of the thing goes here in the middle. There's different kinds of IUDs. This is a copper-containing one. You see the copper wire that's been wrapped around here. Copper prevents ovulation, so by doing so, it prevents fertility. There are also IUDs that have progesterone in them that leak progesterone a little bit for years and years. And because that progesterone is so close to the ovaries, it can be in a very, very small amount and still prevent ovulation by preventing follicular development, like we talked about last time. So that's the IUD. It has a little string at the end so that it can be removed. So the string comes down here so that when removal comes along, it's a non-invasive procedure. So IUDs are put in an outpatient office, and they're removed in an office. So they're a great reversible birth control plan. We talked about the post-coital contraceptives last time. This is a tubal ligation, or a tubes tied, right? There is actually no tying of tubes. They've never done it that way. What they mean is that the tubes are cut and then they're sutured shut so that the egg, ovulation still occurs, so you still have a monthly cycle, but the egg can't reach the uterus and incoming sperm can't reach the egg. So this is permanent, although they will say they can reverse them. That's not 100% effective. And of all of these, this is the most reliable form of fertility management, is the tubal ligation. Even better than the vasectomy, because like I said last time, these can heal. There are quite a few post-vasectomy babies out there. There is the occasional post-tubal ligation baby too, but that's much, much less common. Oftentimes after the second or third pregnancy, physicians, your obstetrician, will offer to do a tubal ligation immediately after delivery because it's the woman's already in the hospital and it's just real quick outpatient procedure. So sometimes they'll do that at the same time. So questions about any of those? Yeah.
Where does the egg grow?
Hmm?
The egg.
Oh, what happens to the egg then? It involutes or it atrophies and disappears here in the ampulla. Yeah, so there is still ovulation. There's no reason why there wouldn't be. The egg can't get from point A to point B. Others? No, I know we talked a lot about this last time. So, all right. A few things that can go wrong with the reproductive system. We talked about the cervix and the pap smear and Gardasil, the human papillomavirus vaccine. Well, all of those things are done to prevent this. Okay, so this is the view of the cervix that many of you will learn how to observe in a pelvic exam. So the observer's looking up this way, right? So you see the end of the cervix at the end of the speculum. And here's the cervical os. This is what cervix is supposed to look like. It's supposed to be nice and shiny because it's a smooth epithelium, right, with a little mucous membrane. This is what cancer of the cervix looks like. So you get this cauliflower-looking appearance. It looks decidedly abnormal compared to smooth and shiny. Now, the problem with cervical cancer is not this part. The problem is cervical cancer tends to spread very easily, and oftentimes by the time it's detected, it's well advanced. In other words, it's grown past the cervix into the uterus, because remember, what you see here is growing up into the uterus too, is growing up this way. And you've got a lot of space in here where cancer can hide for a long time, right? So one of the reasons why the pap smear is done now is to detect this very, very early. If they find something on that pap smear, then they'll go back in, they'll look for areas that look abnormal, and there's a couple of things they can do. One is called a LEEP procedure, L-E-E-P, and that's where they find the abnormal area and they cauterize it. In other words, they burn it off with a sharp loop to take that cancer away. There's cryotherapy that's done. In other words, the area of cancer or precancer is frozen, and once it freezes in place, then those cells die off, and the cancer dies with them. And then, of course, there's the more invasive going in and excising these things, cutting them out. So those of you that are going to take care of human patients, you will learn all kinds of things about these procedures because they're very, very common. Now that we do these pap smears regularly, we find precancerous cells or abnormal cells often. That doesn't mean there's cancer. It just means, you know, there's normal, there's cancer, and there's a whole spectrum in between, right? So an abnormal pap smear means you're somewhere not at cancer, but you're not normal either. So it requires further study and sometimes additional procedures like we talked about. This is another bad one. This is ovarian cancer. Here, ovary tissue has overgrown. This is also a problem because it's not detected until later. To this day, we don't have a great early detection plan for ovarian cancer. The ovaries can't be felt from the outside of the body, right? In the pelvic exam, the bimanual part where there's a hand on the stomach and a hand in the vagina can sort of get to an ovary, but that's about all you get. So because these structures are not palpable, we can't feel them, there's no way to tell if they're enlarged, right? And oftentimes in ovarian cancer, there's no pain, ovulation still occurs, so there's no sign that there's something wrong until it's giant like this, in which case it's usually invasive and you have a poor outcome. Anybody have family or friends ovarian cancer or cervical cancer? No. They're both pretty rare, but when you find it, it's bad because it's usually quite far advanced by the time diagnosis happens. This one you've all heard about. This is breast cancer. So this is a mammogram, right? And this is what normal breast tissue looks like. Remember those suspensory ligaments that we talked about that hold the breast up, attached to the pectoralis major? Well, you can see those in X-ray. That's these guys. But this is the abnormal spot. Now, you can have a mammogram that looks just like this, and everybody gets very concerned that it's breast cancer. They put a needle in here, and they take a piece of this tissue, and oftentimes it's normal. They call it fibrocystic change. So it's non-cancerous. It's just there's an area of the breast that's denser than the rest. But again, the reason we do mammograms once a year after age 50 is to detect cancer of the breast early so it can be removed or treated before it spreads, right? Because breast cancer in place is not a big deal. Breast cancer that's metastasized and spread around the body is a very big deal. Leading killer cancer. And then we have, remember the prostate gland around the urethra? Well, the prostate gland can get either hypertrophy, which we talked about, squeezes the urethra shut so that the male has difficulty urinating. Remember we talked about that in the urinary system chapter. Can also become cancerous. And then the testicle can also have cancer in it, and everybody is familiar with Lance Armstrong's case, and he's a survivor of testicular cancer. Again, just like breast cancer, we teach patients to self-examine because patients can be great early detectors. So with women, we teach them to examine their breasts, and with men, we teach them to examine the testes for looking for cancer. Any change is something to go to the doctor about, so it can be further analyzed and diagnosed. All right. Questions about any of those? Comments? Interesting stories? No? All right. Okay, so that's chapter 25, right? That's the reproductive system chapter. Chapter 26, I've taken a bit of a different approach with, because we start to run out of time at the end of the year. And really, a big chunk of chapter 26 is a whole other course, which is embryology. How the human being, or any animal, goes from a single cell to a complicated organism is a very complex topic. We could talk about it for an entire semester. So I'm going to skip all that. So this is my abbreviated version that we're going to go over. And like you've seen in other chapters where I've done this kind of thing, this, like I say here, the only material that you're responsible for is what's from these PowerPoint slides, okay? Because I'm leaving a bunch of stuff out. But ultimately, we go from single cell, day 1. 4 weeks later, we have this little tiny thing, doesn't look human at all, right? 8 weeks later, so that's just 1 month, we have all the human parts are there, right? The proportions are a little strange, looks like a little alien, but it's starting to look human. So we call this embryology. The embryologic development is from single cell to human-like thing. It has all the human parts, but they're not fully developed yet, okay? Because then from 8 weeks until delivery, we call that fetal development. So the easy way to tell these apart, an embryo is where organs and parts are still being developed, okay? So at some point in development, you don't have a leg yet, right? So you're going to develop a leg. That's happening in the embryo. The heart develops, all the organs develop. In the fetal development, everything's formed. It's just going to grow to its and become more complex. So eyes happen in the embryo, and then in the fetus, those eyes get bigger and more complex. Does that kind of make sense? So this is where all the parts develop. This is where the parts grow to what we think of as infant, all right? So that's the fetus. So at the end of last time, we talked about ovulation occurs and that follicle becomes a corpus luteum. That corpus luteum produces progesterone. Hopefully that's familiar. But that if there's no pregnancy, that corpus luteum goes away. Well, now we pick up the case of, well, what happens if there is a pregnancy? Okay, so we're going to follow from that point on. So ovulation occurs, right, out of the side of the ovary into the uterine tubes. Typically, fertilization occurs about here. Now, it can occur anywhere along this path, but in the typical case, it occurs right here in that ampulla, or the infundibulum of the uterine tube. So here we see that happening. So day 0, these are the sperm, this is the egg. And once one sperm enters the egg cell, the egg's cell membrane locks shut. It changes in such a way that an additional sperm cannot enter the egg at that point. Important, because in order to have a normal cell, you've got to have the right number of genes, right? You've got to have the right number of chromosomes. And if you had a second sperm in there, you'd have one extra set of chromosomes, and that pregnancy wouldn't survive. So you have to have one of each, one egg cell, one sperm cell. And remember, the egg is a huge cell, right? Because it got all the parts of 4 cells. Remember, we had a cell and it split. We had a little cell and a big cell and so on. So we had a giant cell. Well, once fertilization occurs, the first thing that happens is this giant egg cell starts to divide. Now, it doesn't get bigger, it just gets to be in more pieces. Does that kind of make sense? So one of the reasons it comes with all those metabolic resources is so that it can do this trick. Because by day 4, we've got a whole bunch of cells, but the whole thing is no larger. Okay, so this has not gotten bigger. You see that in this picture. It's just gotten more and more divisions to it. And that's because as the now fertilized egg is traveling through the uterine tube, it has no resources from the outside. It's not connected to anything. So the only thing it has is what it brought with it when it started out as a big egg cell in the first place. So for the first 7 days, this fertilized blastocyst is what we call it, but is having to survive on its own without any resources from mom. So it doesn't get bigger, it just gets more and more complicated. So by the time implantation occurs, we call this structure a blastocyst. That word is right here. Blast being new, cyst being round thing, right? So blastocyst. So by day 7 to 10, here, we get implantation in the uterine wall, which we're going to look at in much more detail, okay? So remember the endometrium, how it thickens under response to estrogen, and then it becomes more secretory in response to progesterone. Well, this is why those two things happen. And that's to prepare the endometrium, which is the lining of the uterus, for this event. Okay, so this menstrual cycle, there was a pregnancy. So instead of the menses, or instead of the endometrium disintegrating and disappearing, it's instead going to create its mom's side of the placenta. Okay, so here is that blastocyst coming down from the uterine tube, right? So that's here. We're going to zoom in. And it's a ball of cells, okay? So first it lands, so we call that implantation, where the two connect. And once the two connect, you can see that this structure, okay, the ball on the outside, that's going to become the amniotic sac that the fetus will live in during pregnancy. The cells that are in sort of light blue here, this is going to become the baby. Okay, so it's very simple still. We don't have much structure at all. So these blue cells that are going to become the amniotic sac and the placenta are very active. Okay, so they land, and then this structure literally starts to burrow its way in through the endometrial lining. So this is all endometrium. Okay, so like I say, no need to know specifics here, just the general gist. So the blastocyte attaches to the wall, and then it starts, the cells, through cell division, they start dividing and dividing this way, towards the uterine wall. So then eventually what happens is this soon-to-become embryo burrows its way underneath the surface of the endometrium. So this is the surface of it. So the uterine cavity is out here, right, from our picture. So this is all endometrium. And the embryo is implanted when it's buried itself underneath the surface of the endometrium. So what people often think is that the placenta grows here on the surface. Okay, so this is the endometrium. That's this part. We're right here, right? And people think that the placenta grows here. Well, it doesn't. The baby drills its way underneath that layer and it takes up residence in here, way underneath. Okay? So once it has implanted and buried itself in there, it further elaborates its structure, right? So now we have cells that are going to become the amniotic fluid, or amniotic sac, that's out here. This is going to become the baby, believe it or not, this little plate of cells. And then for a little while, we, even as mammals, have a yolk sac. So you know when you crack an egg when you're cooking the yellow stuff, the reason that's in there for the chicken embryo, is to use as nutrition. It's all of the protein, lipid, fat, or protein, lipid, carbohydrate, and water that the baby chicken would need to develop into a chick. Well, we don't do that, but there is still a time when we have a yolk sac. So it shows our evolutionary heritage. That long before we were live bearers like we are now, we probably, not our ancient ancestors, but way down on the evolutionary tree, this would have been an egg that would have developed outside of an organism. So it's just an interesting point. All right. So in the end, some of these cells, these guys right here, the trophoblastic cells, do you see that? So here's the trophoblast in dark blue or purple. That's here. In a few more weeks, is going to develop into a placenta. Okay, we've all heard, the placenta supplies the baby with what it needs during gestation. Well, what's interesting is the placenta is kind of a joint effort. Its construction is part mom and part baby. In reality, the baby does the complicated stuff. So the baby grows its own placenta. Mom just provides her blood around those structures in order for nutrients to cross. Okay, so the baby's been removed here. This is the amniotic sac, so this is where baby would be. And this is the umbilical cord, which would go into baby's navel. And then on the outside, this is what was the endometrium. Okay, this layer right here, because this is the uterus, and here's the cervix down here to orient you. If we zoom in and look at the structure of the placenta, we see that it's remarkably simple. Okay, so the baby creates these trees of blood vessels. Okay, so arterial blood is coming out of the baby, blue venous blood is going back in, and they form these kind of, we call them villi, chorionic villi, and essentially they're like little tufts, little plants almost in structure. Okay, surrounding these structures is our pools of mom's blood. Okay, so mom's blood enters here, mom's blood exits here. So we have baby's blood surrounded by mom's blood, and it creates a huge membrane for stuff to cross from baby to mom and from mom to baby. Important to note, though, baby's blood never leaves baby's blood vessels. Right? You see that if you follow the blood? Blood comes out, blood goes back. So mom's blood and baby's blood do not actually mix. Another common misconception. They don't share blood. This is how baby can have a different blood type than mom. Because blood cells never cross. Baby's blood cells stay in baby, mom's blood cells stay in mom. Right? So the only interaction the blood has is across these membranes here. So like we've heard a number of times in this semester, what crosses membranes? Small things, typically, right? So carbohydrates, amino acids, fatty acids, oxygen, carbon dioxide, the ions, so sodium, potassium, bicarbonate, all small things. So those pass between baby and mom, but blood cells, being large things, don't. Just like proteins, baby's proteins and mom's proteins don't mix because proteins are too big to get out or in. So that's a very important aspect of the placenta, is it allows mom to provide for the needs of the baby in terms of nutrients and oxygen. It allows mom to get rid of what the baby needs to get rid of, carbon dioxide, urea, things like that, all without mom and baby's blood mixing, which could be a catastrophe if the blood types are different. Yes?
So is that why moms with HIV or AIDS have babies that don't necessarily have?
Correct. Because in utero, which is what we call before birth, the blood cells don't cross. Now, HIV can cross, though. So it's a maybe. Sometimes yes. Huh?
How come HIV can cross? Is it just small?
Because it's small enough. Yeah. Not well, because as viruses go, HIV is not particularly small. It's just particularly nasty. So yes, and in a HIV-positive mom, we would do a C-section to minimize the risk of mom and baby's blood mixing. Yeah. At least that's the way it used to be. I think it's still there. Other questions? Yes.
Can you explain, like, drug addiction, how that would work in this kind of scenario as well?
You mean like cocaine, I can't think of opiates, heroin, morphine. They do cross.
Okay.
They're relatively small molecules. So whatever drugs mom is taking, baby is taking too. So when the baby's born and that supply of drug is cut off, baby withdraws and has all the symptoms. Drug withdrawal, particularly of the opiates in newborns, can be fatal because it's such a stress to the baby. And if you think about it, all their bodies have ever known is having that drug around. So they develop differently too. Same is true for nicotine, same is true for alcohol, all of those things cross the placenta. Yes?
When is this that the placenta forms? Like what day?
Well, it's not like a day.
Oh, right.
It happens. It happens in the first 2 weeks. This structure right here, as this whole thing gets bigger, this evolves into this. So what mom provides is her blood. That's pretty much it in these pools. What baby makes is this complicated system of vessels that sit inside of mom's blood.
So is the delay in the placental development then, is that how, like, if a woman doesn't know she's pregnant right away, like how alcohol or something can't affect the baby right away? Is it because there's no placenta?
No, it can. It's just embryology. That first month is so genetically determined that outside toxins don't usually have an effect. And if they do have an effect, they're so profound that the baby doesn't survive. So mom doesn't ever know she was pregnant. Does that kind of make sense?
Yeah.
So not many things go wrong, but when they go wrong, they go catastrophically wrong. So it's in the first, it's after this phase, so from day 30 to day 90, that's where you get troubles with birth defects and we call them teratogens, where toxins affect development. Because in that embryo phase, that's when organs form, that's when limbs form. So any problem in there, and you're going to have a lifelong issue. Yeah. Yes?
So, sorry, one question.
No, it's
when
fine.
the blastocyte is attaching to the endometrium and a woman takes a pregnancy test, will it be positive at that point? Or is it still too early?
This is just about when HCG starts to appear. HCG, human chorionic gonadotropin, is what they test for in the strips. And it's made by the placenta, which is why it's a great pregnancy test, because if you have a placenta, then you're pregnant. If you don't have a placenta, then you're not. So we pick something that a placenta makes, and we can determine it that way. The new tests, the early predictor ones, about here, because these cells would start to make that hormone, teeny tiny amounts. Good questions. All right. So we've got a placenta. Okay. So perfect lead-in to what hormones play a role in pregnancy. Well, those chorion, the chorionic villi here, in addition to being a membrane for things to pass through, they also produce hormone, HCG, human chorionic gonadotropin. Human, because it's human. Chorion is the name of the baby side of the placenta. Okay. Gonadotropin, we've heard this word before. This tropin is activate. The gonad is the ovary in the female. So HCG doesn't just exist so we can detect pregnancy. HCG also sends a message to the ovary to stop the corpus luteum from disappearing. Remember, if there's no pregnancy, the corpus luteum only lasts about 12 days, and then it disappears. That triggers the menses, which triggers the next cycle. Remember from last time? Well, if HCG is present, the corpus luteum doesn't disappear. It stays intact. And the corpus luteum, you'll remember, makes progesterone. And progesterone is the pregnancy hormone. So of all the hormones that play a role in pregnancy, progesterone is the one you have to have, and you have to have a ton of it. Okay? So progestation, pro-pregnancy, progesterone. That's what it's for. So not only does progesterone get the uterus ready for an implantation, it also supports the pregnancy once that implantation occurs. So the corpus luteum sticks around. It gets a new name, the corpus luteum of pregnancy. It gets larger and larger, makes more and more progesterone and estrogen. And essentially, it is the hormone provider for the first trimester. So if that corpus luteum, if there's a problem with it, the pregnancy cannot go on. The pregnancy will be lost. So one of the things that obstetricians will check is progesterone and estrogen levels. So to make sure that that corpus luteum is functioning properly. Now, after that first trimester, it disappears anyway because by then, the placenta is doing that. So not only does the placenta provide for baby's needs, but the placenta also keeps the uterus functioning as a pregnant uterus by secreting progesterone and estrogen. So it takes over for the corpus luteum of pregnancy. So then at delivery, when the placenta detaches from the inside of the uterus, which it does, all of the hormones that it's been producing stop entering mom's circulation, right? Because the source is gone. The progesterone, or the placenta was making progesterone and estrogen, so those levels plummet in mom, and those plummeting levels of progesterone are what trigger prolactin, which starts breast milk production in mom. So it's a nice, elegant system. When the placenta goes away, the hormones it made drops, that releases the inhibition on prolactin, and the breast starts making milk. Now, in the first pregnancy, like we talked about on Thursday, it takes a couple of days for milk production to actually happen. In subsequent pregnancies, it's much, much faster. But in first pregnancies, it can be 2 or 3 days. All right, so hormone questions? Kind of got that. So HCG, progesterone, and estrogen. Those are the big 3 hormones in pregnancy. Okay? Yes?
Can the drop in progesterone and estrogen also do something? I mean, can that also affect women in other ways, like negative effects of that?
Yes, baby blues is something that happens post-pregnancy, and in part, remember we talked about how estrogen and progesterone had central nervous effects? Well, that occurs too. So mom has been living with very high levels of both, and then they drop. So yes, moms can have any number of different results from that. Even blood pressure issues, because progesterone supports blood pressure, so when it drops, sometimes moms will have low blood pressure for a little while after pregnancy too. All right. People usually get a kick out of this picture, being an all-female school, right? So I call this real estate. The human body is really at an evolutionary edge in terms of our infant size. Compared to other animals, we give birth to giant offspring, right? And it's because our brain, being the hallmark of the human being, is our big heads and our big brains and all the amazing things we can do with it. But it creates a problem in that the brain gets so big that there's not much space for anything else just prior to delivery. Okay, so this is the normal case. You got all this room in here, right? And I know some of you in here have been pregnant, so feel free to chime in on the truthfulness of this. But so here's the liver, stomach, large intestine, small intestine, lots of room, right? Little tiny uterus. There it is, teeny tiny thing. Now, this is full term, 40 weeks gestation, and baby is literally taking up all the space. Okay, so this mess up here is all of this. So it's all of the digestive tract has been shoved up underneath the diaphragm, right? Because there's only so far out the baby can be. If the baby just kept growing out, eventually mom would fall over, right? Because more and more weight would be out here. You can only bend back so much. So it can't be like that. Has to grow up. So here's the small and large intestine. Here's the liver jammed up here. So when women are in late stages of pregnancy like this, it's hard to breathe because your entire digestive tract is sitting up under your diaphragm and there's a baby underneath it. So they much shorter breaths are smaller breaths. Therefore, they have to breathe more often. Okay, so everything gets crammed up. Constipation is often a problem, which easy to see why, right? Hard for anything to get past. I mean, this is all the room that the large intestine has to get past the baby here. Here's the bladder, and you all know that women, when they're pregnant, have to go to the bathroom a lot. Well, it's because they have a 10-pound or 7-pound baby pushing down on this little bladder all the time, not giving it much of a chance to do anything. So when we have that, you see that even still, the baby does stick out quite a bit here, right? So in response to that, it's like carrying something heavy right in front of you. You're either going to fall over or you're going to bend back. So we call that the lordosis of pregnancy, or sway back. And you'll see that as the baby comes further and further out, mom has to tip her shoulders further and further back in order to stay upright so she doesn't tip over, right? So you'll see that. I think I have a picture of that. I guess I don't. So the response to that is to curve the back. Also, when we walk, we don't walk just in straight because of how our bodies are evolved. There's a side-to-side motion when we walk, right? Because mom has this big mass hanging out of, here's her pelvis where the weight is going down. Baby's way out here, so there's a swing effect. If you watch a late pregnancy walk, it goes side to side. The pregnancy waddle, we call it, right? And it's impossible to avoid because you have this big mass out there. To compound all that, in the late stages of pregnancy, the joints start to loosen so that the baby has a little more room to get through the pelvis. If you think about our skeletons upstairs, that hole at the bottom is pretty small, right? So all the joints under the influence of estrogen, the ligaments that hold them together, get a little stretchy so that there's a little more room. But that means mom's hips are a little more stretchy, and she can become very unstable. So not mentally unstable, physically unstable. So we encourage women in 36, 37, 38 weeks, always hold the handrail, because those loose joints, together with 8 pounds of baby hanging out in front, they become a huge fall risk at that point. So encourage your pregnant friends to be careful when they have the big belly sticking out, right? Okay, so everything gets crammed out of the way. And it's not just the 7-pound, 6-ounce, strapping baby girl here either. You've got a bunch of amniotic fluid. It has a weight, right? The placenta weighs about 1/2 pound. So you have all of those structures competing for space in mom. All right. So what kinds of, how does that affect us? Well, first let me just say that pregnancy is not a disease, okay? Sometimes in this country we can think of it like that. Pregnancy is part of the human life cycle. But that doesn't mean that it isn't without its side effects, right? So pregnancy isn't a disease, but it does have effects on mom, which are not always pleasant or positive. Okay, so first, respiratory. Mom is literally breathing for 2. And what I mean by that is the baby is not only growing, but every single one of its cells is metabolizing, and metabolizing at a higher rate than mom's. So we've learned in a couple of places this semester, metabolism requires oxygen. So mom essentially has a very vigorous tumor, right, that's creating a baby instead of a cancer. It's very vigorous, consumes a lot of energy. So moms has to breathe faster and deeper all the time, which increases her own metabolic work. One of the reasons why appetite increases in pregnancy. It isn't just to feed the baby, it's also to accommodate all the things that mom is doing to support the baby's growth, right? So we have increased respiratory rate and depth. We have the mammary glands actually develop during the 3rd trimester. Remember I said that pre-pregnancy, there is no mammary gland in the breast, right? It's just adipose tissue and suspensory ligaments and connective tissue. Well, in the 3rd trimester, those mammary glands actually form in that radial fashion like we looked at the other day. So by the 6th month of pregnancy, the mammary glands are developed, but they're not doing anything yet. They're not producing milk. Milk production doesn't happen until after delivery. Once the placenta is delivered, that's what sends the signal to start milk production. The kidneys have to produce more urine in order to accommodate the baby produces metabolic wastes too. And a common misconception, again, is that the baby's urine is what creates amniotic fluid. That is kind of true, but the baby's urine doesn't have any waste products in it because mom's kidneys are doing that for the baby instead. So it's just water and salt. So mom's kidneys have to work extra. Glomerular filtration rate, which should sound familiar, goes up by about 50%. All the while, baby is smashing down on the urinary bladder, right here. So it's a double whammy. Decreased bladder capacity together with increased urine formation means lots of trips to the bathroom every day for the pregnant woman. So that's here. The digestive tract has to do double duty. So typically maternal nutrient requirements go up by about 30%. So even though the baby doesn't weigh 30% of what mom weighs, the baby is metabolically busier, so it consumes more nutrients for its size than you would think. So about 30%, that's calories per day that go up. And then mom's blood cardiovascular system increases its activity as well. So essentially the baby, through this process, is stealing mom's oxygen all the time, right? As oxygenated blood comes in, the baby's hemoglobin is better at grabbing oxygen than adult hemoglobin is, so it swipes mom's oxygen, which means that not only does mom have to breathe more, but she has to circulate more too, because to accommodate for this oxygen theft all the time. So by the end of gestation, mom's blood volume has increased by, that's a big number, almost 50%, right? So think about that for a minute. If she had 3 liters of blood to start with, she has 4.5 at the end of pregnancy. Now that's for a couple of reasons. One is to provide a faster circulation, but the other is to account for some blood loss with pregnancy. If you've ever seen a baby deliver, it is not a bloodless affair. You know, it's not nice and clean and tidy. So there is blood loss, but mom is prepared for that loss because she's got extra blood on board. It's very uncommon to have to give a blood transfusion to a pregnant woman after delivery because evolution has prepared her for some blood loss as part of that process. So she uses that blood to help her own cardiovascular system, and then at the end of delivery, or at the end of the pregnancy, she has that extra in case there's blood loss. All right. Okay, so questions about any of that before we talk about delivery? Anyone want to rush out and get pregnant? This is usually one of those talks where people are like, I don't ever want, that sounds like a terrible idea. And then 10 years from now, many of you will have little ones running around. It'll be cute and fun, right? All right. So be kind to the late pregnant woman. She's going through a lot, and her body is going through a lot. And at the end, it gets even harder for a little bit, right? Because we get to this. We get to parturition is the technical term for delivery, okay? And it happens in 3 stages. What's interesting is all three stages happen because of the same thing, and that is the uterus contracts. That's why the uterus evolved, to hold the baby and then to evict the baby at the end. Okay, so the uterus is smooth muscle, not skeletal muscle, so it's not consciously controlled. And smooth muscle is very, very strong for its size. Okay, we think of, biceps and quadriceps as big, strong muscles, and the uterus, being only so thin, you'd think, well, what good could it do? But smooth muscle is very strong for its size, and because it is a bunch of cells working together, when they're coordinated and they're all contracting at the same time, the pressure they can generate is quite enormous. Okay? So in the first stage, and we'll talk more about this next time because I know we're running out of time, but in the first stage of parturition, the contractions push the baby's head against the cervix. Here, right, here's the cervix. Uterus contracts and pushes the baby this way. That causes the cervix to get thinner and thinner as the baby squishes it, right? Once it gets real thin, the cervix starts to open, right? So the thinning we call effacement, and the opening we call dilation, all right? And then, once that is full, so once the cervix is fully open, then we have the pleasantly referred to expulsion stage, right? This is the eviction of the baby. So the uterus contracts, pushes the baby out, and then in the third stage, the placenta, which is released at the end of this stage, is also pushed out by the uterus. And then after all three of these things happen, the uterus continues to contract and contract and contract, and amazingly, it goes from this giant thing to just a little bit bigger than this, all in a few minutes after delivery. So it squeezes very, very hard. It hurts a lot for the woman, but the uterus contracts, and by contracting on itself, it effectively stops the bleeding that was caused by the placenta being released, right? So we're out of time, but we'll talk a little bit more about how the first stage happens, because many of you will have questions about that because you've heard things. But questions about any of that so far today? Yes?
So, since that's all smooth muscle and then contractions start over smooth muscle.
Why do you have to break it down? It helps. So
what muscles are you
you're using your the abdominal muscles contract. So you hold your breath and your abdominal muscles contract. That increases the pressure in your abdomen, and it helps the uterus push the baby down and out. So the uterus still does most of the work. It's why there's no point in pushing until the uterus is contracted, which you'll learn when you stand next to women having babies. So everybody waits for the next contraction to occur, and then when that contraction starts, then you have mom push. Otherwise, mom's just pushing and she can't do anything. But when the uterus and mom are pushing at the same time, that's when big things happen. Yeah. And it's why it's really good to stay in shape during pregnancy, because the stronger your core muscles are, the faster and easier delivery is. Because you can just push the baby out. Yeah.
Is it common for the pelvic bone to crack?
The coccyx frequently gets broken. Yep. It depends on if you're, the tailbone. If it points frontwards, the baby will crack it. Yes. If you're lucky enough to have one that points down, though, it's usually not a problem.
So is that common?
Yes. That one is common. Well, she's got so many other things going on at that point that she doesn't feel that pain until later when there's an ache that's usually not there. Sometimes they fix them, sometimes they don't. Like sometimes they'll go in and put it back in its position, sometimes they'll just leave it. Because if you break it in your first pregnancy, you might as well leave it so it won't break the next time if you have another. Yeah. We'll have more time for questions. I know that you all have questions about pregnancy and delivery, but we'll do that next time.
You're scared now.
The intention of today was not to scare you out of having babies.
Right.